topic. I hope all are anesthetists. So this topic is going to be more relevant because this perioperative aspiration. So we all are working since long. Many of you must be working for decade, intubating the patient, anesthetizing the patient, and handling these kind of issues. Am I right? So what do you feel? How many you must have gone through this? What is actually mattering for this perioperative aspiration? Is it only the fasting status of the patient or something else? Yes? Yes, maybe. Yes, like emergency you are talking about, emergency situations where trauma is one of the most common emergencies we used to have, where we don't know the actual prandial status of the patient, okay? Yes, OBS patients where the physiology is deranged, there is like she told about diabetic patient, gastroparesis is one of the important causes. So delayed impetting. So all of those comorbidities which lead to delayed impetting of the stomach is posing hazard not only for the patient, for the anesthetist also, because once you had it, then you are going to keep those patients for a long time, and what is going to happen next is this kind of aspiration pneumonias leading to mortality up to 5%. And if you take aspiration pneumonias, due to aspiration occurring the pneumonias leading to other causes also, if you combine together, the figures are quite high. It is 9% mortality. If you talk about morbidity as such due to perioperative aspiration, we don't know our own data, but other data is very high. So keeping these things in mind, what we do usually for checking the prandial status? What do we do? History. So we used to go with these kind of guidelines, like ASA guidelines, which says if you are having nothing, 2 hours. If you have something clear, liquid, then there is something more hours. So that is usually 6 hours, and with full diet, having high calorie and fat, we go for 8 hours. But still, if you combine, who comes to the for anesthesia and surgery? Those who are having comorbidities. So taking these things in mind, is a lot of work has been done. To obviate these aspiration issues. So either we are going for standard methods for combating the aspiration, which takes RSI and this and that. Many of these tracheal intubation, apart from going for the other shorter versions of anesthesia or simpler version of anesthesia, we used to choose other more complex versions, okay? So keeping these in mind, many people worked on using this ultrasound for knowing the prandial status, okay? So can we know the prandial status? Yes. By scanning the stomach, we can know what is there, whether it is actually empty or having something there. If something, what kind of? Because we are feared of particulate matters. If it is a clear liquid, then the chances of post-op aspiration, pneumonitis is maybe less. If we are having solid food particles, maybe high. So if we can know this particular patient is having empty stomach, if not, what kind of risk, whether there is a particulate kind of, okay. So keeping that in mind, I am going to let you know about how you are going to do this gastric ultrasound, okay. So we all know that stomach is having anatomically the fundus, the body, the antrum, okay. So these 3 parts mainly we are going to assess by ultrasound, okay. So how we are going to do it is we are going to use the probe which can penetrate deep, that is a low frequency probe. So usually the large convex probe, you all must be aware till this time, okay. This is the large convex probe, low frequency, by which we can penetrate deeper, okay. So we all know this side is the spleen hanging over the fundus of the stomach. Okay, left side, usually the spleen long axis is along the 10th rib, and if you go down, then you will encounter the body and finally the pylorus, antric part and the pylorus. Okay, so these are the areas anatomically where we are going to put our probe and trying to assess the stomach. Okay, so these are the positions commonly explained, but most feasible and accurate method is this right lateral decubitus. Okay, but if we talk about critically ill patient, trauma patients, we cannot make them in our preferred position. That's why you have to go ahead with the supine position many times. Okay, so keeping these two in mind, will take you through how to do it: fundus, body, and this antrum part. Okay, so coming to the most important part is the antric part of stomach. Okay, so what we do for antrum, we put our probe in epigastric region. Okay, epigastrium, longitudinally pointed towards head inside, and we scan right and left. Okay, so by this time you must be familiar with this lever. This is the lever. Okay, so this is lever, and here you can see some round structure is there. Can you see this? And this side you will get the great vessels, okay, like aorta, IVC. Okay, sometime you may have supramesenteric artery or vein. So keeping those things in mind, this lever here and the great vessels here, you will encounter this stomach. Okay, so can you play this video? Just click on the video. Okay, पूरा फोल्डर नहीं लिया क्या? अरे पूरा फोल्डर लेना था. पूरा फोल्डर ले रखा. नहीं, जस्ट तो वीडियो चलेगा नहीं. इसको रन करता है. Okay, so this is the lever. Okay, can you see here the great vessels, and this is the pancreas here. So just anterior to this is the antric part we are having. Okay, so very little amount of anechoic area, that is some fluid inside. Okay, so this is the antric part. Can you see here round this is? Okay, so Rahul, can you do? We'll try to have the live also. Okay, just watch here. Can you see the lever? Lever. This is, what is this? This is heart, and this is connecting is the IVC. And if we go this side, we will get the aorta. Okay, so here we are going to get the antric part here somewhere. Okay, can you see here? This, if we make him right lateral, इधर करवट हो जाए थोड़ा सा. Okay, just थोड़ा सा, बस. Just watch here. Say collapse one right now. Okay. This. Can you see something is moving inside here? See, is the fluid inside. Some fluid with particulate matter is there. So this is the antric part. Okay, so we are going to put our probe longitudinally, curvilinear probe in the epigastric region, just right and left. You try to get the lever, posteriorly some great vessel, and in between, just superficial, you will get near the lever, the antric part. Okay? Slides. कर दो इसको. Okay. So coming to the body, if you just slide your probe towards the left, just slide your probe towards the left, just flatten it. Okay. So earlier we were having longitudinal, now we are going transverse. Then you will get the body. So body will definitely have, if you are dealing with a patient who is having something inside, they will have more fluid inside. Okay. And it is again these are the layers of stomach. Okay. Can you play the second video? Basically मैं उसी से करते हैं ना, पेन ड्राइव से. Okay, can you see? So this is again anechoic area is inside here, and we are getting some particulate matter. Can you see here down? These are some other bowel part. Okay, maybe the colon. We may be having the colon, some part of colon. Okay. So again you need to differentiate between some other bowel part versus the gastric, okay, or the stomach. So definitely you are going to get 5 layers. Can you see these thick layers, multiple layers are there? Okay. It is more clearly visible while somebody is having empty stomach. Okay. More clear visibility of all the layers. Stomach is having distinct 5 layers. So first from inside out you will get the air mucosal line. So air will appear bright, okay, hyperechoic. Then you will have the muscularis mucosa, that is hypoechoic. Then again you will have the submucosa, which is again hyperechoic. So air line hyperechoic. Then you are having the hypoechoic. Then submucosa hyperechoic. Then thicker muscularis propria, that you will be again hypoechoic. Then serosa is hyperechoic. These are 5 layers. So we are not going in detail about that. So this is the stomach body part. Coming to the fundus. For fundus we have to go laterally towards the left axilla. Okay, putting the probe longitudinally, go up and down. Then try to rotate your probe a bit like this. Okay. So first longitudinally in axilla. Okay. Trying to see the spleen and kidney. That is the usual fast window of left upper quadrant. That's why you can see in this. This is the liver, this is the spleen, the diaphragm, and this is the kidney. So try to get this first, and then you come a bit anterior and just tilt your probe. Okay. So first we were having this kind of longitudinal, and now just tilting like this. Okay, just angling like this, coming more anterior. So then you will see this is the spleen, and here you will get this fundic part of the stomach. Can you see? The spleen is coming in view, and here you will get the stomach, that is the fundic part will come here. Just wait. See here. Maybe not. Okay. Okay. But out of these 3 areas, antrum is supposed to be the most accurate projection of whatever gastric volume is there overall in the stomach. Okay. So we are barging on the antric part. Okay. So again epigastric, longitudinal, right and left. Try to see the great vessels, liver, and in between you will get the stomach. Okay. So then slides. Okay. So antric is more important. Antrum is more important to assess always. Okay. We all know that there is baseline secretion. Baseline secretion is there. Okay. So even if you keep the patient fasting, there will be something. Not at all it is going to be complete empty, both the walls are adhered to each other kind of. Okay. You will have something. Okay. So if you see the empty antrum, both the walls will be like this, maybe some fluid is there, maybe. Okay. If we see some clear fluid like we seen right now, okay, in all videos, clear fluid, So anechoic, totally anechoic. If you have full diet, solid, then you are going to get echogenic glass ground kind of appearance inside the antrum. Okay. So we came to know assessing the antrum. Then calculation of volume is another point which we have to consider, because it is the amount. Okay. More fuller, high likely of greater amount aspiration is there. Then liquid or particulate matter. Okay. So if they are having full stomach with solid food, the antrum will appear having echogenic or ground glass appearance. Okay. If there is a solid content. Okay. So with this all, just to culminate all those things what we had discussed right now, we follow one algorithm for knowing the prandial status of the patient and risk of perioperative aspiration is, if you see we are talking about antrum in two position, one supine, one right lateral decubitus. Okay. So if it is empty, it's a low risk. Okay. If you are having solid food particles like ground glass appearance, a very high risk of aspiration following to pneumonia and all. Okay. If you are having fluid, then I told there may be a baseline secretion. So for assessing that, you have to think only in right lateral decubitus you are getting the anechoic area. It fairly says that the fluid amount is less than 100 ml. Okay. And by many physiological studies, we know that usually the secretions are less than 1.5 ml per kg. Okay. So we take as 50 kg or 60 kg even is roughly coming 90 ml. Okay. So if you are getting fluid only in right lateral, it's a fine. Clear fluid right lateral only, it's fine, less than 100 ml. If you are getting both in right lateral decubitus and supine, it says it is more than 100 ml. So it is high risk. So we can leave here by doing grossly, or we can study further for assessing the actual fluid volume, especially in pediatric population where we cannot go ahead with this. Okay. So for that you have to take weight of the patient, and then whatever picture you are getting, just freeze that, use the ellipse, and you can calculate the volume in usual way by the machine. Okay. So by that you can think of gastric fluid volume. If it is less than 1.5 ml, it's fine enough. If it is more than 1.5 ml per kg, is again high risk. Then you have to go with all those precautions, take care of the patient to prevent the aspiration as much as possible. Okay. So any query, any question? Okay. Or we can discuss during the skill session. Okay. So thank you very much.